All right, we have about 5 minutes for questions. And while folks are coming to the microphone, I want to remind you, first of all, there is an app that you can download that will give you slides and information about the meeting. Second, please don't forget that Dr. Castanos is going to have a live discussion about the drug-coated balloons and mortality in the industry area following this session. And third, there's a number of lunch symposiums that you're all encouraged to attend. Question?
Hi. Yeah, good morning. I'd just love to hear from the panel, just when you see people back in a month or two, how do you decide who you're going to retrieve the filter from? And just, maybe I'm lazy, but just older people, I usually just leave them in, and younger people, I'm sort of aggressive about retrieving them.
I wouldn't leave a temporary filter in anyone. The data is just too high for fracture and complications. So if you have an elderly patient like in their 90s, I would recommend putting a permanent filter in if that's what you need to do. And in everyone else, I would retrieve them. The retrieval process a month later is very simple, very straightforward, very low risk. The complication rates for IVC filters now is reported to the FDA is up to 12 to 15%. We all know that that's probably quadruple that with what's not reported. So I would not leave a temporary filter in as a permanent filter personally ever.
So I really have the same approach you have. The older people I leave, specifically if I put the option filter or certain of the other filters that are approved as permanent, and most of them are approved as permanent actually. The problem is with the certain type of filter, I'm not going to choose the name here, these you have to be very careful with because they fracture, they migrate. Actually, we had one recently fracture, even not supposed to fracture. You can deal with the complications later. So if you don't expect the patient will have a life expectancy beyond certain time, and that differs from one person to the other, you can leave the filter really.
So for me, it's pretty much what's their life expectancy right now. If they have a longer expectancy of 6 months, that filter's coming out unless they can prove to me that it's not going to come out, which is it should be zero. Whether it's a permanent, quote unquote, old permanent filter, whatever it is, we see even, and we got to use the term old very carefully, 85 is the new 82, but there's people who are elderly who have complications from these filters. I mean, I'm in wound care clinic. We see venous ulcers that all propagated from having this filter in the first place. So I don't think there's such a thing as too old or a filter, or they're too old to have it out unless their life expectancy or prognosis is so bad. That's the only time I'm going to leave it in.
I think more importantly, there's one prospective randomized trial on filters. There's not much survival data that filters improve survivability. And if you even look at the trauma data, you have to treat a large number of people before you prevent a significant pulmonary embolism with a filter. So I think we need to study this better. But in general, if you have someone who develops a calf vein DVT, I would highly recommend doing a follow-up ultrasound on that patient every 48 hours, because most of these patients can be put on anticoagulation within a week, and they don't need a filter at all. It would be much less expensive on someone who's in the hospital and sick like this, rather than getting a filter, to follow their lower extremity exams and see if they really need a filter. I think the only indication would be someone, with an active bleed and an extensive DVT where they really are at high risk for a pulmonary embolism. I think we're putting in probably 10 to 20 times the number of filters we should even be putting in.
I agree with all these points. The other thing I would say is if you just have trouble getting patients back for removal, you can consider a Sentry filter or something that will release on its own.
Yeah, but one other thing one should consider is that sometimes you see patients coming to you because they've heard these ads and they have a filter which is 10 years old and they are not having any symptoms. And in those people, if it is 10 years, 8 years, there is no reason, in my opinion, to go and put them through the risk of filter removal with metal fatigue and causing more problems. Just leave them alone.
Yes, sir. So consensus on iliofemoral versus femoral popliteal. When do you determine who to use some catheter-directed thrombolysis? Can we start at the other end of the table?
So I tend to be more conservative. I don't touch fem-pops unless you have phlegmasia. Otherwise, the sweet spot for catheter-directed work is iliofemoral DVT, so I use it exclusively for that. Never for anything below the inguinal ligament unless you're dealing with phlegmasia.
So almost similar approach. I usually give my patients symptomatic iliofemoral DVT 48 hours of anticoagulation. If they still remain symptomatic or with a swollen leg, I intervene. FemPop, conservative approach.
I keep mine to above the inguinal ligament. Iliofemoral DVT to prevent long-term post-thrombotic syndrome, and certainly in all phlegmasia patients.
I agree. Symptomatic iliofemoral DVT, but because I attack them from the POP approach, I clean out the femoral vein at the same time, obviously.
More along the same, but with the anticoagulation, if the FemPop doesn't improve and they're very symptomatic, I will intervene on those as well. Depends on how anticoagulation responds to those patients, and we follow them up very closely. I don't want the young person with FemPop to become chronic.
So I hardly do for FemPop only, but if it is associated with iliofemoral, I do lyse it at the same time. But they have to be symptomatically really bad, and they have a good life expectancy. I mean, you cannot, because we are talking about PTS most of the time now, nothing else.
Dr. Ansel.
Hi, Gary Ansel from Columbus, Ohio. I'll take offense by what some of you guys have said because you don't have any data to support this. But if you look at why we don't put in, or that we're putting in too many IVC filters, it's the clinical guidelines of bleed and thrombosis is as bad as death. I can tell you, since that FDA letter, I've seen 6 people die from massive PE, all driven by, we're putting in too many IVC filters. I disagree with you vehemently. We're not putting enough in at many of the institutions that have become too restrictive. The problem with IVC filters is the doctors aren't good. They don't take them out. You take them out, the risk goes away and the protection's everything. And I can tell you, if I've got a patient with a massive PE and they've got a big DVT load, and I'm going up there to fix it, I'm going to put a filter in them. Why? Because those patients die. But I can tell you, when we get up and we say 30 times too many IVC filters, it's a disservice to the field. And the reason being is all they hear is you shouldn't put any in, and that's not the case. What they should be hearing is we have to be very appropriate and thoughty. But if you want to put in extra ones, other than the financial problems with that I have, that's okay, but take them out. Or use one that bioconverts on its own. One of those two things.
Gary, would you say that you're lucky because you have excellent partners?
I am extremely lucky because I put them in, I make you take them. No, I'm just kidding. But I do think that, you know, as we've gotten, we're starting to, everything in medicine does this. And I'm an old guy, so I've seen it too many times. The pendulum swings way too far one way, then it swings too far the other way. And I'm just being offensive just because when we say massive numbers of way too many and we just shouldn't be putting these in, I get it. That was appropriate when we were putting in a whole bunch more about 5 years ago. But they're really decreasing, and I can tell you the ones I'm seeing now is because they aren't being appropriately put in anymore, so that the numbers are really getting to be bad. I'm really worried about our community hospitals because they don't want to put any of them in because they don't want to take them out. But we got to protect the patients that have significant disease processes.
All right. So I think we're a couple of minutes over. Certainly, if you guys have any additional questions, the faculty will be around today and hopefully through the rest of the week. But I'd encourage you to go to the industry area. Let's hear about drug-coated balloons and the mortality and the concerns. Thank you.